to Beyond the Scales, starting the obesity conversation, where we unravel the complexities of obesity. I'm Emily, and I'm joined by my co-host, Fran.
Hi everyone, we're two medical students on a mission to demystify obesity, as there's so much more to this topic than just a number.
We're joined by Consultant Bariatric Surgeon, Mr Humphreys, who's working with us on this podcast. He brings a wealth of clinical expertise to help us navigate this complex condition. Hi, Lee.
Hi, Emily. Hi, Fran. Nice to speak to you again.
Nice to see you.
This week, we were wondering if you could talk to us a bit about a career in bariatric surgery. So could you start from the beginning of how you became a surgeon?
Yeah.
Wow. How did I become a surgeon? The honest answer is I couldn't think of anything else to do. I think I like a lot of people. When I left medical school, it was quite clear that I was going to be a surgeon. For many character traits that will be obvious to people that know me. And originally, like a lot of people, I wanted to be an orthopedic surgeon, and I wanted to do that for ages. And then I did 6 months of intensive care and really enjoyed it, and decided I quite like looking after sick people. So I went away from a career in orthopedic surgery. Sorry to all my orthopedic friends out there. And decided on general surgery. And then of all the sort of general surgery subspecialties, it was quite clear that upper GI was the one that suited me. So I became surgical registrar and declared a subspecialty interest in upper GI surgery. And that's really the path. And bariatrics is sort of, it doesn't really have its own subspecialty training recognition yet. So upper GI surgery is broadly split into benign upper GI surgery, esophagogastric cancer, and then bariatrics. And most trainees will declare either a cancer interest or a benign interest without bariatrics, and then some trainees will now declare a bariatric interest. And all that means is that towards the last couple of years as a registrar, you may spend more time in your declared subspecialty training fields. And that depends a little bit on your region and what hospitals are available in those regions as to where you go. But the path is the same for anyone who wants to be a consultant in surgery. You've still got to pass the FRCS. And the exam is still the same. It doesn't really discriminate whether you want to be a bariatric surgeon or a cancer surgeon or whatever. So you don't really start to subspecialize, really. Most people will end up doing a fellowship in bariatrics. So you'll pass your exam, and then depending on your program director and how you fit it in with your training, you can either take time out and do a fellowship within your training, or some people then finish their training and go off and do a fellowship, what's often referred to as a post-CCT fellowship. And then you'll usually spend a year, some people slightly longer, but just concentrating on doing the thing that you're interested in. So if it's bariatrics, it's bariatric surgery.
So is that almost as you've mentioned, that not every hospital has bariatric surgery?
No.
Is that your way of getting into it? Is by taking that fellowship?
Yeah, so I mean, I think if you want to become a consultant bariatric surgeon, it'd be difficult to get a job if you don't have a bariatric fellowship, because we all recognise that lots of trainees don't get a huge amount of exposure to bariatrics as part of their training. Even the ones who are really keen and know they want to be bariatric surgeons from early on. And so the beauty of a fellowship is that you spend a year concentrating on doing bariatric surgery, doing the clinics, dealing with the complications, and so that then puts you in a much better position to start as a day one consultant, and knowing that you're reasonably confident to do the types of surgery that you'll be expected to do as a day one consultant.
In terms of subspecialty within the specialty, once you go down your, say you're interested in more, say esophageal cancer, as you mentioned, are you kind of permanently there, or can you change and later go into bariatrics, or is that kind of the end of it?
Yeah, that's a very good question, Emily. And indeed, so some people do. I mean, I've got 3 colleagues now currently who are all esophagogastric cancer surgeons, as indeed I was. I did esophagogastric cancer for 5 years before I gave it up to concentrate on the bariatrics. But and they do bariatric surgery with me now. They all did cancer fellowships, but because we work in a unit where we do both, and some of them were registrars with us, so they got exposure to bariatric surgery. Then we've mentored them as they've started as consultants, even though they've got a cancer interest, they do both, and so we've mentored them in the bariatrics as well. It's getting increasingly rare now to have units that do both cancer and bariatrics, but there are still some around.
What is your typical week like? So I think a lot of people see on TV, they think surgeons are just in theatres all week, but what is it really like?
Yeah, if only. I think if you work outside of the UK, then surgeons spend most of their time in the operating theatre. In the UK, certainly, it's usually 1 day a week in theatre. Some weeks it might be 2, but if you average it out over the year, for most people it's 1 all-day list a week. Then I will do an average of 1 clinic a week, 1 endoscopy list a week. Then you throw in on calls, and then time for admin. There's a lot of admin. Being a consultant surgeon, you'll spend a lot more time doing admin than you do doing surgery, I'm afraid. That is the way of things. So less time in theatre than most people think, sadly.
Would you say it gives you kind of a bit of variety though, so you're not just doing kind of one thing?
Yeah, I mean, it depends what you enjoy. Some people love endoscopy. I don't mind endoscopy. It's great. It's a fairly low stress thing to do, and it's another skill to have. Now, for example, in Europe, it's and I believe in the US, it's very rare for surgeons to actually do endoscopy. They rely on the gastroenterologists to do it all. In Britain, most of us will also do endoscopy as well. And I do think it's important, particularly for dealing with your complications and assessing people before surgery. I think, if you need to understand the anatomy of the operations that you're doing. Particularly if you have a complication post-bariatric surgery, if you're not trained in doing the surgery and you don't understand the anatomy, then interpreting what things look like on an endoscopy after surgery can be quite difficult. And increasingly, there are newer and more interesting endoscopic techniques available, some of them coming out now to help treat obesity. So I think it's important to be able to endoscope. And certainly in the UK, it's a requirement if you're going into upper GI or colorectal surgery that you're competent in colonoscopy, lower GI endoscopy, or upper GI endoscopy at the end of your training.
I don't want to go too much off a tangent, but you hear quite a lot of trainees talking about how it's becoming almost challenging to get that endoscopy experience, particularly with other healthcare professionals also becoming now qualified and interested in doing that as well.
Yeah, I mean, it can be. Again, it depends on your unit. It depends on the setup. I mean, we're in a very busy tertiary referral hospital, and there's endoscopy lists running 6 days a week in multiple different rooms. So our trainees don't really struggle to get access to endoscopy. They may, but in other hospitals you may do. But there shouldn't be a huge shortage of endoscopy. But sometimes it's difficult getting it between theatres and clinics and all the other things that you need to do. But I also sit on the ARCP panel for registrars in the deanery, and we're not often hearing about people who are struggling to get their endoscopy numbers.
What do you have to do? Kind of, you graduate medical school, then what?
So you graduate medical school, you would do your foundation program. You would then compete to become a core surgical trainee. You do your core surgical training. You then compete to become a specialty trainee. Then once you're into your specialty training as a registrar, then the sort of process that I described earlier from ST3 to ST8, that's when you start to declare your subspecialty interests and you work towards that. I think the other thing that people probably wouldn't understand is that being a bariatric surgeon is not all about the surgery. I think what makes it very different to a lot of other specialties is there's a lot of psychology involved, and I think obviously people there's a lot of, as we've spoken about in other episodes, there's some bariatric patients are really quite complex, and you have to have an appreciation of that as a surgeon operating on them. You have to understand the mindset, and you have to understand the challenges that they go to, which are quite unique in getting bariatric surgery. And sometimes I spend time in clinic and I come away from clinic thinking I sound like a psychologist most of the morning rather than a surgeon. And I think that is quite unusual. Although, all specialties have certain groups of patients that maybe require a different touch to others. But I think the other thing about bariatrics that's one of the big challenges, and we've touched on this in previous episodes, is the fact that you sort of have to fight all the time to get your specialty recognised. So we've already discussed that obesity is not recognised as a disease in the UK. And so I and my other obesity treating colleagues in the weight management services, we spend a lot of time advocating for our patients and pushing the agenda of why we should be treating more people, why we should be treating them earlier. And, you don't really get that in many other specialties, and it can be quite tiring. And I think you've got to really be passionate about obesity and bariatric surgery to do this. Because if you're not passionate about it, then you will lose that energy and that drive to keep championing the cause and keep pushing things forward. And then you just become a technician. And some people might be happy with that, but I don't think most of us are. So I think that is one thing that people may not appreciate that does make it quite hard sometimes.
Yeah. And what would you say are the best parts of being a bariatric surgeon? What are the highlights?
I mean, the highlights are quite simply the huge difference that it makes to patients after you've treated them. I mean, seeing people 6 weeks after surgery where their lives have literally changed in a short period of time is extremely gratifying. Seeing people go home the day after surgery with their type 2 diabetes in remission, off all their medication, that's a great thing. And, the number of times that people will say, this has genuinely changed my life. It's great. I mean, and, it's similar, people talk about cancer surgery and curing people of cancer, and that's a brilliant thing. And I experienced that when I was doing cancer. But I think, the obesity treatment is as genuinely life-changing as cancer surgery can be. And so, that's the big high, definitely. And obviously the flip side of that, with any surgery, is when you get the complications, you get the lows as well. And fortunately, bariatric surgery is very safe. But, when complications happen, and they do happen to all of us, sometimes they can be very significant and very difficult to deal with. And patients can be in hospital for months with a serious complication. And that's the downside. Nobody wants that, but they do happen, I'm afraid.
Yeah. So dealing with that obviously requires a certain type of personality as well. And you mentioned earlier at the beginning that when you finished medical school, it was quite obvious to you that you were going to become a surgeon. I'm thinking particularly of the more junior medical students, that to them, they won't necessarily understand what that means yet. What do you think are quite key attributes to become a surgeon, and particularly, do you think there's any specific to bariatric surgery or not?
I mean, interesting. So for me, I didn't decide to do bariatrics until really quite late in my career, in my training rather. I think, there are a general, and I'm stereotyping a little bit here, but a lot of these things do hold true generally. So most surgeons are good decision makers, work well under pressure, are pretty forthright in their views on lots of things. And I think generally we're good problem solvers. We want to get things done. We're quite goal orientated. So, you'll see that on a surgical take. It's quite a fast paced environment. We're always pushing, right? Where's that scan? Right? Who's next in theatre? Why isn't that result back? Let's push. What do we need to do? Because that's how you process people and move them forward. Wow. And so I think decision-making skills and time management skills are key, I think. And that's probably true of all consultants, but faster paced specialties, particularly where you do acute on-calls, those are really key skills. Being able to operate, obviously, most people would think that's a good skill, but for most people, you can teach that. There are very few people that you can't teach to operate. But some of those key personality traits you can't teach. And so, if you're someone who doesn't like being in a fast-paced environment, doesn't like juggling plates, metaphorically, doesn't like being under pressure, doesn't like having to make rapid decisions and live with the consequences, then surgery is probably not for you.
What do you think about the teamwork side of things? So my experience in theatres is there's lots of people, you all work together quite smoothly. So how do you think that comes into?
That's incredibly important. And team working is a hugely undervalued skill. But you're absolutely right. The theatre environment, team working is crucial. And I think being able to change it up a little bit depending on the circumstances. So I think most of the time when I'm in theatre, it's a very relaxed environment. If the situation allows, there's plenty of laughing and joking, people enjoying themselves, and that's great. And you need to be part of that as the consultant surgeon in theatre, along with the consultant anaesthetist, who are usually the two most senior doctors in there. And so you are the leaders in the theatre often. But most of the time, there is in my theatre anyway, there's not really a significant hierarchy. It's a flat hierarchy, and people need to be able to feel free to speak up, because sometimes, one of the HCAs may notice something. And if they don't feel free to speak up, then, things can get missed. And that's how things run most of the time. But let's say, for example, you're in a trauma situation where you've got a patient who's bleeding and you have to act very quickly and very decisively, then you need to be able to switch it up from being that team member to really being a leader and having to say, look, actually, this is a life-threatening condition. I need to do X, Y, and Z. I need you to do this for me. I need you to get that. I need just very clear, concise communication and give direction to people so that everyone knows what is expected of them. And that's not an ego thing. That is you have to grip it. You have to take charge, because if you don't give clear direction, people don't know. People aren't mind readers, and people need to know. And it's okay to say, look, actually, this is a really difficult situation. We've got life-threatening bleeding here. I'm going to need to, I need everyone's attention until we have dealt with this. And when you work as a good team, people will respond to that in the right way, and people will, up their game, switch it up a gear, and everybody knows that there's a problem, and until that problem's dealt with, and then we can all calm down and relax again.
Yeah.
So there are people talk about leadership, and leadership's a really important quality. We don't teach leadership very well. We don't teach it in schools. We don't really teach it in medical training, although formal leadership training sort of is coming through. But most of us have learned leadership through osmosis, or we've worked for people that we have been inspired by, think, well, they're a good leader, and we try and emulate them. But, if you go to an interview, people will, a common interview question is, tell me about your leadership style. Well, I don't think good people have one leadership style. I think your leadership style depends on the situation. And we've just described two very different situations where my leadership style will be very different, because it needs to be. And so I think that that's something that people need to consider. But you are thought of as a leader, as any sort of consultant. But as a surgeon, as I said, along with a consultant anaesthetist, you are the leaders in theatre. Doesn't mean you're the overall decision makers. Those days are gone. But yeah.
So just touching on that point about, as an interview question, about, what kind of leader are you? Do you also get asked about other character traits in a more of a formalised question way, or?
You might do. I mean, there are lots of situational questions that people can get asked, and these are designed to sort of see how you might react in a certain question, say in a certain situation. So you've got the things like, tell me about a time you failed.
Yeah.
Or tell me about a time when you've done something you're really proud of. And I think that at first they can be quite difficult to answer. I think certainly the things that you're proud of, because as doctors, we're not very good at talking ourselves up. Well, most of us aren't anyway. And we feel quite uncomfortable and quite embarrassed about it. But it's an important thing to be able to do. And then, tell me about a time when you failed. The key with that question is spinning out the learning. So say, okay, I failed because this happened, but actually what I've learned from it, and now I do this. So it's the person asking that question. If you just sit there and tell them about a time when something went horribly wrong and you haven't learned anything from it, or haven't changed the way you practice, for example, then you're not going to score very well in that. But if you turn that negative into a learning point and a positive, then you should score higher in a question like that. But these are common questions, not just in medicine, outside of medicine, in industry as well.
So younger medical students who maybe, feel that they don't have the skills that we're talking about so far, but are interested in becoming a surgeon one day, what would you say to them? Would you say, don't worry, you'll have experiences and you'll be able to answer those questions later on? Or what would you?
Yeah, I mean, a lot of it does come from the day-to-day job.
Yeah.
And if you've got specific interviews coming up, you can do courses, or you can ask people who have done that to practice questions with you. But again, if you're interested in learning about leadership or becoming a leader, whatever, then there are multiple courses that you can go and do that can teach you the theory. I think the other thing about teamwork that probably should mention, as a bariatric surgeon in particular, we do a lot of multidisciplinary team working. So I've talked about theatre, but actually outside of theatre, I work very closely with a nurse specialist, with dietitians, with psychologists, with physician colleagues. So I think multidisciplinary team working is a really crucial part of being a bariatric surgeon and treating obesity. And you do have to be able to work with people from various different backgrounds, allied health professionals. And I personally think it's very important that you treat everyone the same. And everyone has got different areas of expertise, and they may not be consultants, but they know more about psychology, they know more about nutrition than I do. And so you have to respect their expertise and know when to call on it. And I think, team working is a really, really important part of being a consultant. If you can't work well in a team, then your life is going to be difficult and your colleagues' lives are going to be difficult. And you may be the best surgeon in the world, but if people don't want to work with you because you're not a team player, you're going to struggle to get a job. Because, you need people around you. When things go wrong, when we have complications, when we have difficult times, being able to call on your colleagues and say, actually, can you stick your head into theatre? I'm not sure what to do with this. Or, this has happened in clinic. What would you do? That's a key part of the job. And you never stop learning. I've been a consultant for 10 years. Every month I'll come across something I haven't seen before, probably, or don't quite know what to do with. And so I'll ask one of my more experienced colleagues. And I think that's good behaviour, and I think that's healthy. The days of, particularly surgeons being lone wolves should be long gone, because that's not good for patients. It's not good for you either, because, eventually that sort of thing can lead to poor behaviour, increases risk of burnout. You've seen a couple of high-profile surgeons in the news where who've done things that maybe they shouldn't have done, and a lot of that comes from this sort of siloed working, and that was very common 20, 30 years ago. It is far less common now, for good reasons, I think.
Just wrap things up. Do you have any kind of final advice or tips for any aspiring surgeons out there?
I think if surgery is something that you're interested in, then start talking to people about it. Start talking to the person who's on the next step of the rung of the ladder for above you. So, if you're a medical student, start talking to a foundation trainees or core trainees. If you're a core trainee, start talking to a specialist trainee, because if you really want to get there, you always need to have an idea of what's the next hurdle. So is it passing the exam? Is it, what's the checklist to qualify to get for an ST3 interview? You need to be thinking about that stuff a year, 18 months ahead, because when you need papers and publications and presentations, all of those things take time. They always take longer than you think, and the really good people are always planning 2 moves ahead. And I think that's my advice: is speak to people doing it or have recently done it. What did they do? Find out someone who's been really successful. Say, look, actually, could I have a look at your CV? Or can you tell me what steps you took to get onto a core training program or a specialist training program? And just start using these good role models, because there are plenty of them around. So real world experience and asking is key. Never be afraid to ask. Most people are very happy to help and very happy to share their experiences if they're approached in the right way.
Yeah, what you're describing is mentoring, really. And,
exactly. It's informal mentoring. And
it's common in the US, and yet here it's been around, but it's certainly increasing in popularity. Even the word mentoring.
Yeah, and I think it's probably something that we've all done informally. I mean, I've done a bit of formal mentoring in my time as well. Yeah. And again, you can now be trained in how to be a mentor, but most of us have sort of picked it up along the way, again, by being mentored by someone who did it well. Yeah. And I still think in Britain there's a lot of this. It just sort of happens by osmosis or happens by accident rather than happening by design, really. And I think we probably do need to get better at it. As I said, I think leadership is an incredibly important thing that's not taught very well. And being able to mentor other people is also something. And as you will find, as you become doctors, when you become a foundation doctor, you get over being terrified about being a foundation doctor. And then you're a core trainee. And then all of a sudden, people are coming to you and asking you questions. You're like, oh, hang on, a year ago, I was the one asking questions. Now I've got to learn how to be a core trainee, and I've got to look after this foundation trainee as well. And so every time you go up the seniority ladder, there's more of this stuff. And I vividly remember every time I took that step, it was like, oh, what's going on? People expect me to know stuff. Like, oh, I've got to do operating, and now I've got to worry about what they're doing. It was like last week, I just had to worry about where I'd left my BNF. See, there's an old school reference. You don't have to worry about that anymore.
No, it's always no, we haven't step BNF. It's just yeah.
But no, and talk to your colleagues, talk to your friends. I still think going for a beer after work, particularly if it's a bad day, is a very underrated way of decompressing. Clearly, I'm not encouraging people to drink too much. I wouldn't do that for bad behaviour. But a social, that sort of social gathering and just a shared experience is a really important way of decompressing and sharing out those difficulties. And I think that maybe a lot of that's been lost a little bit by shift working. I think it's one of the big downsides of what has happened with surgical training over the last 20 years, that the loss of that firm structure and everyone sort of having the feeling being in it together. Although there were downsides to that, and I'm not for 1 second saying, everything was great. It wasn't. But the sort of camaraderie and the feeling of all being in it together and everyone going to the pub together after a difficult day to talk about it was a very good thing. And a lot of that's been lost. And I think it's easy, particularly when you rotate, as foundation trainees, 4 months in a team, with the on-calls and the time off and everything. It's actually really difficult, particularly for consultants, to get to know you. And I think if you want to be a surgeon, or whatever specialty you want to be, if you're doing that job at the time, then the more you get noticed, the more you try, because people that stand out are people that go out of their way to maximize their educational opportunities, and you will get noticed for doing that.
What about people that maybe are more interested in going part-time? Say they have other interests that they wish to pursue alongside surgery, or want to be part-time because they want to be, I don't know, a mum or a stay-at-home dad part-time. What happens there?
So, increasingly, less than full-time training is becoming common. And that's a good thing, because there's no doubt that surgical training has been a barrier for lots of people, particularly women, because women have tended to have more family commitments. Rightly or wrongly, that's a very traditional way, but that has tended to be the way, and that's one of the reasons why traditionally there were far fewer female surgeons than men. And thankfully that balance is changing quite dramatically. But we are, it's no longer, it's not frowned upon in any way to be a less than full-time trainee. And there are accommodations made all over the place. Now, I think that, usually that's done for family reasons or health reasons or whatever. I think, asking to be a less than full-time trainee because you've got a side hustle going on. I'm not quite sure we're there yet. I can see the trend coming through, and I can see, I can see in another 10 years, maybe that will be the norm. But I don't think your program director will buy the buy the YouTubing side hustle as a reason for being less than full-time at the moment. But then we're all old and we're not in touch with it anymore.
I'm amazed at how many people in our year have already businesses, or certainly business ideas that they're slowly working on now.
I think that's a whole nother episode.
Yeah, we'll have to talk about that.
Yes, well, thank you very much for speaking with us again. Make sure to like and subscribe, everyone, and we'll see you for the next episode.
Thank you so much.
Pleasure. Bye.